Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of August 2008. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. We'll begin with the current Treatment in Psychiatry feature, which focuses on Asperger's syndrome. Treatments for schizophrenia will be highlighted, beginning with 2 trials of new compounds. Anantha Shaker and colleagues report a pilot study of xanomeline, a selective muscarinic receptor agonist, and AJP Editor-in-Chief Robert Friedman and colleagues describe a Phase 2 trial of a nicotinic receptor agonist. These studies are discussed by Jeffrey Lieberman and colleagues in an editorial, Cholinergic Agonists as Novel Treatments for Schizophrenia, the Promise of Rational Drug Development for Psychiatry. Then we'll feature a study of the pharmacokinetics of erapapersall by Gerhard Grunder and colleagues. This will be followed by a report from the CATIE investigation on the relationship of cognition and psychopathology to functional impairment in schizophrenia. These 2 articles are examined in an editorial by Donald Goff on clinical response in schizophrenia. We'll also highlight 2 comparisons of brain anatomy in first episode and chronically ill patients with schizophrenia. A meta-analysis examined gray matter volume in these 2 groups, and a study using diffusion tensor imaging revealed differences in white matter. Finally, we'll present new evidence of frontal lobe dysfunction in schizophrenia, provided by 2 studies using different methods. An editorial by Daniel Mathalon and Judith Ford characterizes these as top-down and bottom-up approaches. Let's begin with treatment in psychiatry, which features a problem in current clinical practice. This month, Karen Toth and Brian King present Asperger's syndrome, diagnosis and treatment. They discuss the overlap between this disorder and high-functioning autism. The DSM-4 criteria for Asperger's syndrome are based on intact cognitive ability, no delays in early language milestones, and fewer symptoms than in autistic disorder. However, this doesn't imply that language acquisition in Asperger's syndrome is normal. For example, there may be deficits in the social use of language or use of overly formal or repetitive language. Relatively few studies of genetic and environmental factors in Asperger's syndrome have involved large and well-characterized samples. One long-term study of 100 boys with Asperger's syndrome found that 50% of the sample had a paternal family history of autism spectrum disorder. About 25% had pre- or perinatal risk factors. In another study, a genome-wide scan for Asperger's syndrome identified 2 susceptibility loci on chromosomes 1 and 3 that have been implicated in autistic disorder. A comprehensive assessment for Asperger's syndrome should include a detailed developmental history and a review of social, communication, and behavioral development. Direct observation of the patient is also essential. Screening is also needed to detect seizures, sleep difficulties, disruptive sensory issues, anxiety and depression, and other psychiatric and behavioral disorders. It is also important to review school records and ask teachers about their observations. Assessment of intellectual, language, adaptive, and neuropsychological functioning may further inform educational planning, and an occupational therapy evaluation may help determine strategies to mitigate sensory issues. Finally, addressing the family system may also help improve outcomes for children with Asperger's syndrome. For example, by lessening stress and depression and by increasing access to community resources. The most common comorbid diagnosis in individuals with Asperger's syndrome is depression, which occurs in as many as 41% of patients. Care must be taken when diagnosing schizophrenia and psychosis because the intense preoccupations and interests seen in persons with Asperger's syndrome can resemble delusions and disorders of thinking. In these cases, a detailed history must be obtained to determine whether these idiosyncratic interests were present before the onset of the presumed psychosis. The average age at diagnosis of Asperger's syndrome is about 11 years. This is problematic because the prognosis is related not only to cognitive and language abilities, but also to the provision of early interventions to improve social competence. No single method or intervention has been identified as the most effective. Often, a combination of behavioral, developmental, and social approaches is used. A primary focus is enhancement of social competence. Strategies include direct instruction, role-playing, modeling, practice with peers, constructive feedback, and the social stories technique. This last method refers to stories that can be written and illustrated to fit any scenario. The goal is to provide information on what people in a given situation are doing, thinking, and feeling. Pharmacotherapy for associated conditions in Asperger's syndrome has not been systematically studied, so currently it's informed by research in the general population. Now we'll turn to 2 studies of new drugs for schizophrenia. The first report is by Anantha Shaker and colleagues, titled Selective Muscarinic Receptor Agonist Xanomeline as a Novel Treatment Approach for Schizophrenia. All of the currently available antipsychotic drugs are presumed to act predominantly by antagonizing various dopamine receptors. However, preclinical data suggests that agonists with selective affinity for cholinergic muscarinic receptors provide a potentially new mechanism to treat schizophrenia. Xanomeline is a relatively selective muscarinic type 1 and type 4 receptor agonist. In this double-blind study, 10 patients with schizophrenia were randomly assigned to placebo and 10 were assigned to xanomeline. Over 4 weeks, the xanomeline group had greater improvements in the Clinical Global Impression Rating, the total score on the Brief Psychiatric Rating Scale, and the total score on the Positive and Negative Syndrome Scale. In a battery of cognitive tests, xanomeline produced better outcomes in verbal learning and short-term memory. The other antipsychotic drug trial we're featuring is by Robert Friedman and colleagues. Their report's titled Initial Phase 2 Trial of a Nicotinic Agonist in Schizophrenia. The medication is a partial alpha-7 nicotinic cholinergic agonist called DMXBA. A crossover design was used to compare placebo and 2 different doses of the drug. The lower dose was 75 milligrams twice a day. The higher dose was 150 milligrams twice daily. 31 patients with schizophrenia received each treatment for 4 weeks, and the 3 treatments were separated by 1 week of placebo. The patients also continued their current antipsychotic drugs. Over the 3 treatment arms, there were no significant differences between drug and placebo in scores on the Matrix Consensus Cognitive Battery. However, several measures of negative symptoms showed significantly greater improvements with the higher dose of DMXBA than with placebo. These included the total score on the scale for the assessment of negative symptoms and the scores for anhedonia and alogia. The lack of difference in cognitive measures suggested that the repetition of the tests in the 3 treatment arms had influenced the results. Therefore, differences among treatments in just the first arm of the study were examined. This analysis showed that both doses produced improvements in attention compared to baseline levels. Working memory improved significantly in the patients taking the lower dose and non-significantly in those taking the higher dose. Jeffrey Lieberman and colleagues provide perspective on these 2 studies in their editorial, Cholinergic Agonists as Novel Treatments for Schizophrenia, the Promise of Rational Drug Development for Psychiatry. It has long been known that acetylcholine plays an important role in cognition. Several findings link it to schizophrenia specifically. there is evidence for decreased numbers of both muscarinic and nicotinic acetylcholine receptors in schizophrenia, and a functional polymorphism of the alpha-7 nicotinic receptor has been linked genetically to this illness. Moreover, acetylcholine modulates dopamine transmission in the striatum and cortex. Dopamine dysregulation in the striatum may contribute to both positive and negative symptoms, and in the cortex, these deficits have been postulated to contribute to cognitive problems. In addition, heavy nicotine consumption is common among patients with schizophrenia, and it's been suggested that muscarinic receptor agonism by clozapine or its active metabolite may underlie its potential improvement of negative and cognitive symptoms. Cholinergic transmission is mediated by two families of receptors, nicotinic acetylcholine receptors and the muscarinic receptors M1 through M5. Numerous challenges have limited the development of drugs targeting cholinergic receptors in the central nervous system. Because their binding sites are similar, it has been difficult to design drugs with high specificity for the various subtypes of muscarinic and nicotinic receptors. Selective targeting of muscarinic CNS receptors over peripheral receptors has also been a significant problem, since the tolerability of drugs is often limited by peripheral side effects, such as cardiac or gastrointestinal problems. Targeting nicotinic receptors is complicated by the limited availability of compounds selective for particular subtype combinations and by rapid receptor desensitization. Despite these challenges, the Friedman and Shaker reports hold glimmerings of positive results. These studies signal the potential of cholinergic agonists as novel therapeutic agents in schizophrenia. They follow the recent publication of positive results for metabotropic glutamate receptor 2 and 3 agonist used as a monotherapy on the basis of the glutamate hypothesis of schizophrenia. These encouraging results suggest that the tide may be turning in experimental therapies for schizophrenia, and that rational drug development for psychiatry may have finally arrived. Now we'll turn to a dopaminergic antipsychotic. Gerhard Grunder and colleagues present brain and plasma pharmacokinetics of erapapersall in patients with schizophrenia, an 18F-falipride PET study. Erapapersall is a partial dopamine D2 agonist that occupies more than 90% of striatal D2 and D3 receptors at clinically effective doses. Most second-generation antipsychotics preferentially bind to receptors outside the striatum, however. Fluorine 18-falipride is a high-affinity radiotracer that allowed the authors to characterize both striatal and extrastriatal binding with positron emission tomography. They examined 16 inpatients with schizophrenia or schizoaffective disorder who were receiving erapapersall. After the PET scans were performed, receptor occupancy was calculated as a percent of reduction in binding potential relative to unblocked values measured in 8 age-matched, medication-free patients with schizophrenia. The results showed that erapapersall almost completely saturated both striatal and extrastriatal D2 and D3 receptors over a wide range of serum levels. The widespread saturation is in contrast to the preferential extrastriatal binding of other second-generation antipsychotics. Furthermore, the rate of erapapersall's dissociation from D2 and D3 receptors was very low. Its long serum elimination half-life and its almost complete D2 and D3 receptor occupancy suggest that under clinical conditions, D2 and D3 receptors must remain nearly saturated for as long as 1 week after the last dose. Significant extrapyramidal side effects were not found, even among patients with the highest serum concentrations. Next, we'll highlight the report from CATIE, the Clinical Antipsychotic Trials of Intervention Effectiveness. This article is by Samaya Muhammad and colleagues, and it focuses on the relationship of cognition and psychopathology to functional impairment in schizophrenia. Functioning was measured with the Heinrichs-Carpenter Quality of Life Scale, which is a rater-completed scale on the basis of a patient's self-report. A second indicator was the number of days of employment in the preceding month. These two measures were examined in relation to psychiatric symptoms and cognition in more than 1,000 participants with schizophrenia in the CATIE study. Assessments were conducted at baseline and at the 6-month and 18-month follow-ups. Cognitive functioning was measured with a battery of tests covering 5 cognitive domains. Symptoms of schizophrenia were assessed with the subscales of the Positive and Negative Syndrome Scale. Neurocognition, positive symptoms, and negative symptoms were independently associated with quality of life, with symptoms contributing somewhat more than cognition. Over the 18 months of the study, changes in neurocognition and in positive and negative symptoms were significantly associated with change in quality of life. Donald Goff discusses the Grunder and Mohammed articles in his editorial, New Insights into Clinical Response in Schizophrenia, from Dopamine D2 Receptor Occupancy to Patients' Quality of Life. He contrasts erapapersall, which is a high-affinity D2 partial agonist, with traditional D2 antagonists. The antagonists achieve antipsychotic efficacy by occupying 60% or more of D2 receptors, thereby reducing overall D2 activity by roughly the same percentage. As a partial agonist, erapapersall in theory would need to occupy a higher percentage of D2 receptors to achieve a similar overall reduction in D2 activity. In fact, previous results indicate that the therapeutic threshold for erapapersall may be greater than 80% occupancy. By modestly activating D2 receptors in the striatum, erapapersall largely prevents classic neurological side effects. Although other atypical agents also avoid extrapyramidal side effects, Grunder and colleagues demonstrate that this feature of erapapersall is not the result of preferential binding to temporal limbic dopamine receptors. It is the nature of partial agonists that these side effects are avoided even at high saturating doses. The low propensity of erapapersall to produce neurologic side effects may in part account for the extremely high blood levels. These telltale side effects indicate the upper limit of a therapeutic window with other antipsychotics. No evidence for an upper limit has emerged for erapapersall. In the Grunder study, some patients had D2 occupancy levels below 80% and serum concentrations below a level associated with D2 receptor saturation. Given the very large variability in serum concentrations and D2 occupancy, and the weak correlation between dose and serum concentration, further trials with fixed doses are needed to examine the predictive power of serum concentrations to guide dosing. If a serum concentration of either 100 or 150 nanograms per milliliter is validated as a therapeutic threshold, the data in this study suggests that a dose of 20 or 30 milligrams per day would ensure adequate D2 occupancy for most patients, although the levels would far exceed the therapeutic threshold in many patients. Another factor that may contribute to the very high blood levels is erapapersall's long half-life. A 72-hour half-life presents both challenges and potential advantages. When treatment is initiated with erapapersall or when the dose is changed, it takes roughly 2 weeks before steady-state concentrations are achieved. Clinicians are accustomed to titrating antipsychotic doses at intervals as short as every couple of weeks in response to symptoms or side effects. The very slow buildup of erapapersall in the blood means that dose increases may occur before the full clinical effect of the current dose is evident. On the other hand, the slow elimination of erapapersall can result in therapeutic levels of D2 blockade for as long as a week after discontinuation. This suggests that erapapersall may be an intermediate option between short-acting oral antipsychotics and depot preparations. For the many schizophrenia patients whose adherence is inconsistent, missed doses of erapapersall will not significantly lower D2 occupancy and hence jeopardize efficacy. The CATIE study reported by Mohammed and colleagues provides a more macroscopic view of treatment. The finding that cognition is a primary determinant of functioning in schizophrenia has been well replicated, but the relative contributions of symptoms and cognition to disability have varied. Demonstrating the relationship between disease-related deficits and community functioning is complicated by the difficulty in measuring functioning. Scales measuring quality of life differ in their focus and their reliance on subjective and objective ratings. The quality of life scale is completed by a trained rater, mostly on the basis of an interview with the patient. It tends to produce scores that correlate with ratings of negative symptoms. Subjective assessments of a patient's satisfaction are important in assessing the appropriateness of care, and they are reliable predictors of treatment adherence. However, self-reports of functional status correlate poorly with assessments made by direct observation. The author's mixed model regression analysis, controlling for potentially confounding factors, establishes that both cognitive performance and symptoms contribute to disability in schizophrenia. The symptoms contributed more than cognitive performance in this study. The important message for clinicians is that community functioning is determined by a complex interaction between the capacity for functioning as reflected in cognitive performance and limitations on the realization of this capacity. In addition, monitoring patient satisfaction with quality of life is essential to enhancing treatment compliance and identifying meaningful interventions. Now we'll turn to two comparisons of brain anatomy in first episode and chronic schizophrenia. The first is by Ian Ellison Wright and colleagues, who report The Anatomy of First Episode and Chronic Schizophrenia, an Anatomical Likelihood Estimation Meta-Analysis. The authors analyzed 27 MRI studies that provided data on individual voxels throughout the brain, rather than defined anatomical regions. Meta-analyses were performed when at least 2 studies providing suitable coordinates were available. Abnormalities in the volume of gray matter in patients with first episode or chronic schizophrenia were identified by comparing them to non-schizophrenic subjects. Gray matter abnormalities were compared in first episode and chronic schizophrenia by means of a subtraction meta-analysis. The anatomical differences in first episode schizophrenia broadly coincided with a basal ganglia thalamocortical circuit. These changes included bilateral reductions in gray matter in the caudate head, which were absent in chronic schizophrenia. However, there was a marked correspondence in the regions affected by both first episode and chronic schizophrenia. These abnormalities included gray matter decreases in the thalamus, the left uncus and amygdala region, the insula bilaterally, the anterior cingulate, and the left inferior frontal gyrus. Decreases in cortical regions were more widespread in the chronic schizophrenia than in the first episode patients, suggesting a progression. The authors did not find evidence for a temporal limbic progression of pathology from the hippocampus to the amygdala. In both first episode and chronic schizophrenia, there were also regions of gray matter increases. In the first episode schizophrenia patients, these involved the left putamen only, and in chronic schizophrenia, the increases included the putamen bilaterally. Our second article on the anatomy of schizophrenia over time concerns white matter abnormalities. Joseph Friedman and colleagues report diffusion tensor imaging findings in first episode and chronic schizophrenia patients. Disruptions in the structure of white matter tracts are becoming an accepted part of the pathophysiology of schizophrenia on the basis of evidence from genetic and histopathological studies. The technique of diffusion tensor imaging has provided indirect in vivo evidence for disruptions in the coherence and organization of white matter structures in schizophrenia. The vast majority of these studies report significant and widespread alterations of fractional anisotropy in the white matter of chronically ill patients. However, studying chronic illness cannot address questions about the timing of the observed changes and their possible interactions with continued white matter development in adulthood. The comparison of first episode and chronic schizophrenia included 80 patients. Each one was individually matched for age, gender, handedness, and ethnicity to a healthy comparison subject. Fractional anisotropy data were generated for 5 brain regions: the forceps minor, forceps major, inferior longitudinal fasciculus, and the genu and splenium of the corpus callosum. The patients with first episode schizophrenia had lower values than their comparison subjects in the left and right inferior longitudinal fasciculus, but these differences fell short of statistical significance. Those with chronic schizophrenia, however, did have differences in the left inferior longitudinal fasciculus and in the right forceps minor. Smaller differences were seen in the left forceps minor, right forceps major, and in the corpus callosum. Now we'll conclude with the studies of frontal brain functioning in schizophrenia. The first is by Zhang Yun and colleagues, titled Association of Dorsal Lateral Prefrontal Cortex Dysfunction with Disrupted Coordinated Brain Activity in Schizophrenia, the Relationship with Impaired Cognition, Behavioral Disorganization, and Global Function. The study specifically focused on cognitive control, the coordination of thoughts and actions that facilitate goal-oriented behavior. Patients with first episode schizophrenia and healthy comparison subjects were examined with functional magnetic resonance imaging during tasks that required cognitive control. The authors hypothesized that activation of the dorsolateral prefrontal cortex would be impaired in the schizophrenia patients, and that this dysfunction would be associated with disrupted coordination between the dorsolateral prefrontal cortex and a distributed brain network that supports cognitive control. The neuroimaging data were analyzed by individual regions of interest and by individual voxels across the brain. The cognitive control task was a version of the AX continuous performance task. The subjects were asked to press a button with their right index finger when they were shown the letter X after the letter A. They were asked to press a button with the right middle finger in response to all other stimuli. The condition with the highest demand on cognitive control was a trial in which the letter X was preceded by the letter B. The patients with schizophrenia had significantly reduced accuracy in the BX trial relative to any other condition. Functional MRI imaging revealed dysfunction of the dorsolateral prefrontal cortex during the trials using the letter B as a cue. The schizophrenia group also didn't show any enhancement of functional connectivity between the dorsolateral prefrontal cortex and the task-relevant brain regions. This impaired connectivity was significantly correlated with worse task performance, greater behavioral disorganization, and lower global functioning. Next, we'll turn to the study by Fabio Ferrarelli and colleagues. Their report is titled Reduced Evoked Gamma Oscillations in the Frontal Cortex in Schizophrenia Patients, a TMS EEG study. They used transcranial magnetic stimulation combined with high-density EEG to directly examine the properties of thalamocortical circuits in the brain without engaging patients in cognitive or motor tasks. TMS was applied to the premotor cortex of 16 patients and 14 healthy comparison subjects, and the EEG responses were then measured. 3 to 5 sessions were conducted at various TMS doses. 3 aspects of the TMS evoked responses were analyzed: amplitude, synchronization, and source localization. Relative to the healthy subjects, the schizophrenia patients had a marked decrease in evoked gamma oscillations within the first 100 milliseconds after TMS. This was particularly the case for a cluster of electrodes located in the frontocentral region. These oscillations were significantly reduced in amplitude and synchronization. Furthermore, the TMS evoked brain activation underlying the gamma oscillations in patients with schizophrenia did not propagate as it did in healthy subjects. Since these responses were evoked by direct cortical stimulation rather than a behavioral task, they were not affected by motivation, attention, or cognitive capacity, and were not relayed through peripheral afferent pathways. Therefore, the findings suggest that frontothalamic-cortical circuits in individuals with schizophrenia may have an impaired ability to produce and synchronize gamma rhythms. The two articles on brain functioning are discussed by Daniel Mathalon and Judith Ford in an editorial, Divergent Approaches Converge on Frontal Lobe Dysfunction in Schizophrenia. They characterize the cognitive challenge used in the Jung study as a top-down approach, in that the task involved inhibition of prepotent responses. The explicit engagement of cognitive functions that are deficient in schizophrenia is a strength of this method, which captures the cognitive states relevant to the illness during assessment of dorsolateral prefrontal function. However, the resulting performance deficits potentially confound interpretation of the brain data. If patients are doing something different than comparisons during the task, their patterns of brain activity are bound to be different. Only the correct trials were analyzed, but it could be argued that the patient's performance indicates they were performing the task differently than the comparison subjects. A related confound is the possibility that patients' performance deficits and corresponding abnormalities in brain activation resulted from lack of attention or motivation. Finally, complex cognitive tasks often engage multiple cognitive processes, so there is uncertainty about the purity of the comparison between conditions. For example, while the contrast between the B and the A cues is thought to isolate control processes related to overcoming prepotency, B is less probable than A. Low probability stimuli in a stream of frequent stimuli can evoke an involuntary orienting of attention. If they are relevant to the task, they can also engage top-down attentional resources related to target detection. Both of these responses to deviance elicit the P300 event-related brain potential. It's known to have reduced amplitude in schizophrenia and to be generated from distributed regions, including the dorsolateral prefrontal cortex and inferior parietal lobule, which are implicated in the Jung study. The Ferrarelli study took a minimal task approach. This method is bottom-up in that direct stimulation of the frontal cortex obviated the need to engage cognitive processes. The evoked oscillations had a frequency in the gamma band, 30 to 50 Hz. This is a ubiquitous oscillatory frequency subserving communication between distributed neuronal assemblies during sensation, perception, and higher cognitive processes. The strength of the minimal task approach is that it eliminates differences in performance, task strategy, general attention, and motivation. Although transcranial magnetic stimulation also bypasses the sensory channels, the approach is otherwise similar to passive sensory stimulation paradigms, such as auditory and visual steady-state driving. In these conditions, stimuli repeat rapidly at a specified frequency, driving the cortical EEG activity at that frequency. Prepulse inhibition, paired click P50 suppression, and mismatch negativity are other passive electrophysiological paradigms that have revealed functional brain abnormalities in schizophrenia. Similarly, in functional MRI, resting state studies of schizophrenia have shown dysfunction of default mode networks. However, minimal task approaches are not without limitations. First, they generally lack face and ecological validity, and they often have limited criterion-related validity from the standpoint of sensitivity to clinically relevant cognitive deficits. Second, they do not necessarily eliminate confounding differences between patients and control subjects in cognitive states. In the absence of task demands, subjects engage in their own idiosyncratic thought processes. Methods that passively probe brain function may evoke responses that are modulated by subjective state variations that differ between patients and comparison subjects. The authors of both studies link their findings to a mechanistic failure of neural oscillations, possibly mediated by deficits involving the neurotransmitter GABA-aminobutyric acid, or GABA. However, whether the frontal lobe dysfunctions revealed by these two approaches arise from the same pathophysiologic mechanisms must be determined from studies in which both approaches are applied to the same patients. Ultimately, the power of these approaches is maximized by exploiting their differences, integrating insights derived from each, and exploring whether they are sensitive to the same or distinct underlying pathophysiological mechanisms in schizophrenia. This concludes the audio highlights of the August issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Thank you.